Greetings everybody, and welcome to Silverio Lining. Today we'll be discussing sodium, in particular, low sodium. How low can you go? First, let's remind ourselves of the causes of hyponatremia. You can have hyponatremia because of input problems, and you can have hyponatremia because of output problems. One cause of hyponatremia that I saw just this weekend with the half marathon in the city is increased water consumption in the setting of normal perspiration. Another cause of input-mediated hyponatremia is hyponatremia. Let's move on to output-mediated hyponatremia. Diabetes insipidus will cause hyponatremia, mostly because the patient cannot pee without peeing out salt, and they usually replete their dehydration with fluids. In case you can't tell, those are sugar cubes going into my morning coffee. Another common cause of output-mediated hyponatremia is simple kidney failure. You can sometimes tell what type of hyponatremia a patient has based on their volume status. Hyponatremia would cause the patient to be euvolemic or volume up. Kidney failure would cause a patient to be volume up. If a patient has hyponatremia because they've been exercising a lot and have been perspiring greater than input, they'll probably be even or volume down, and a patient with diabetes insipidus is likely to be volume down. Let's move on to treatment for hyponatremia. The treatment arms for patients with hyponatremia depend primarily on whether or not the patient is seizing. If they are seizing, you have a license to treat their hyponatremia a little bit more aggressively in addition to your normal seizure medications, Ativan, phenytoin. The sodium concentration you would give a seizing hyponatremic patient is 100 cc's of 3% normal saline straight into their venous system. If a patient isn't seizing, however, and happens to be low volume, you can give them isotonic normal saline. Normal saline actually has 154 milliequivalents of sodium, which is about 10 milliequivalents greater than normal body sodium. You can always start with 2 liters of normal saline. This will likely increase their sodium if they're hyponatremic. It is very important to consider your timelines when you are treating hyponatremia, because there are strict guidelines in terms of how much you can increase somebody's sodium. Within the first 6 hours, you should only increase sodium by approximately 4 to 6 milliequivalents. Within the 24 hours after admission, you should increase the total body sodium by less than 9 milliequivalents. For every 100 cc's of 3% saline you give, you can expect their sodium to increase by 2 to 3 milliequivalents. And why these strict rules about sodium repletion? Demyelinating axons. Don't do it. Thank you for joining, and I hope you feel so good at making the sodium so much better.